you. The next speaker will be Dr. Santosh HONAVAR. He will be talking about ocular surface tumors and role of brachytherapy.
Okay, before Santos, while waiting for Santos, just for your information, because we have quite a lot of speakers today and we have limited time. So I believe that you have a lot of questions, but we want to have a QA at the end of the session. Thank you.
Good afternoon. I'll be speaking about the role of plaque brachytherapy in ocular surface tumors. Historically, about a percentage, 25 to 40% of ocular surface tumors recur following surgical excision, thus precluding vision salvage, eye salvage, and each recurrence adds to metastatic potential. That is the reason why we need to have fewer number of recurrences, and we depend on several oncological principles. One of the most important oncological principles when you surgically excise a ocular surface tumor is edge and base clearance at surgery, and if required, histopathology guided adjuvant therapy. I'll be stressing on these aspects. While edge is easy to determine, you can see it on slit lamp evaluation, base is opaque. You can clinically evaluate the base by trying to move the tumor with a wet cotton tip applicator. That's all. But beyond that, how do you know how deep is the tumor? In such a situation, OCT and UBM come to help. They'll be able to tell you the depth of the tumor and if there is any scleral or corneal stromal invasion. As you see here, this patient has normal stroma here, whereas under the tumor, the stroma is splayed and also hyperreflective, indicating that the patient has full thickness corneal stromal involvement. The only way we can deal with it would be either a penetrating keratoplasty or perhaps plaque brachytherapy. So you don't have a clinical clue when the tumor is opaque. Good news is that imaging correlates very well with histopathology. Here you see a situation where the conjunctiva is involved, tenons, that bubbly layer, is not involved, and that's exactly what you see on histopathology. So when there is good clinical imaging correlation on histopathology, it's easy to determine scleral invasion. But there are clinical situations where scleral invasion may not be detectable because the tumor may have excessive keratin that causes shadow artifacts. In patients who had scleral or limited intraocular extension, earlier we were considering extended enucleation or orbital exentration. Perhaps now we can consider plaque brachytherapy. We use ruthenium, which is a beta emitter. And before you begin plaque brachytherapy, you have to determine whether you want to do it as a primary situation or a secondary situation. Primary plaque brachytherapy always follows this strategy where you confirm the diagnosis on clinical evaluation and, if required, do an incisional biopsy. Primary plaque brachytherapy is reserved specifically for situations where if you want to excise the tumor, there could be loss of integrity of the eye, such as patients with a corneal stromal melt, patients with a necrotic tumor. Where you try to excise this tumor, you will have a corneal scleral perforation, which is not easy to repair. In these situations, we go for a biopsy from a safe zone, confirm the diagnosis, and treat rest of the tumor by a primary plaque brachytherapy without even excising it. So clinical diagnosis followed by exact measurement of the tumor, followed by measurement of the depth of the tumor, and then dosimetry for the estimated height of the tumor, surgical excision and insertion of the plaque. This video clip shows the excision of mucoepidermoid variant of ocular surface cutaneous neoplasia, which has recurred thrice over multiple surgeries done elsewhere with no base clearance in previous surgeries. Although the base was reported positive by the pathologist, the prior surgeon did not take care of it by adjuvant therapy. And patient promptly had a local tumor recurrence, multifocal local tumor recurrence over a matter of 3 months. And again, the patient had involvement of the insertion of the extraocular muscle as well. This was a desperate situation because the other eye was a case of childhood trauma and the patient had poor vision in the other eye, and this eye fortunately had good vision. So we are hooking the muzzle, that's the lateral rectus. We are disinserting the lateral rectus muscle. We are excising the part of the lateral rectus that was involved. So we do an MRI to see the extent of the muscle involvement as well. Excise the tumor in flush with the scleral surface, not doing any sclerectomy at all so that we don't lose the tectonic support of the sclera. apply plaque to the base of the excised sclera. Then if the larger area needs to be covered, we can easily rotate the plaque. Rotate in the sense we remove it at the end of the exposure and apply the plaque again to a different area. So that is definitely possible. So with plaque brachytherapy, we were able to give good success to this patient who had full thickness scleral invasion. This is the post-operative outcome. This is a patient with full thickness scleral invasion, again with treated with plaque brachytherapy. Corneal stromal and scleral invasion with OSSN, treated with brachytherapy. Corneal stromal invasion and anterior scleral invasion, treated with plaque brachytherapy. Now, this was a patient with necrotic tumor and corneal stromal melt treated with primary plaque brachytherapy, and this is the outcome. So we don't have to worry about completely excising the tumor as long as the plaque can be easily placed over the tumor. This is one more example of primary plaque brachytherapy. Of course, there are complications. Limbal stem cell deficiency is an issue, so we currently do primary simple limbal epithelial transplantation in these patients where there is extensive involvement of the limbus. In conjunctival melanoma, of course, we can do plaque brachytherapy. The process is the same. We estimate the thickness of the tumor. We do a UBM to see if there is any ciliary body involvement. This patient does have ciliary body involvement, as you can note, but it is still treatable. The steps are the same. I'll skip the video for lack of time, but this patient was treated with brachytherapy. Extensive conjunctival melanoma arising from prior excision did not take care of the margins or the base, and the patient has multifocal recurrences, all of which was excised, and the scleral involved area was treated with brachytherapy. This patient has a scleral invasion, again treated with excision and brachytherapy, doing well. Extensive conjunctival melanoma with partial scleral involvement, treated with brachytherapy. So in summary, I would say that tumors with corneal stromal or scleral invasion or limited anterior segment invasion need multimodal approach. They need to be excised, of course, with 4 mm clinically clear margins. Lamellar sclerectomy is optional. You can excise in flush with the sclera. I would not prefer to do lamellar keratectomy at all. Alcohol-assisted keratoepithelectomy is only for the corneal epithelial component. Double freeze-thaw cryotherapy, as usual, goes to the edge, not to the base. Adjuvant plaque brachytherapy in a primary or a secondary sitting would definitely help you reduce the local tumor recurrence rate. Of course, finally, there is histopathological correlation.